Hello, everyone. I hope you all are fine and doing well. Uh, we previously talked about a lot of tropical parasite infections, where we talked about the giardiasis, amoebiasis, schistosomiasis, and the hydrated disease. Now we'll be discussing about the different plasmodium, or rather, we will discuss about the arthropod-borne diseases, where we'll discuss about the malaria, dengue, Zika, and the yellow fever. Right? Remember that you have to watch the main lecture from the e-focus. This will be somewhat the exam oriented class where we'll just discuss about the management and the investigations of each and every disease, right? So yeah, let's discuss about the arthropod borne diseases. And the first part, the first is malaria, then we have dengue, then we have Zika virus, and then we have yellow fever. Remember that the malarias and the average, we have different types of plasmodiums. We have Plasmodium falciparum, we have Plasmodium ovale, we have Plasmodium knowlesi, we have Plasmodium vivax, and the Plasmodium malariae. But the average, for the sake of MCQ examination, we take an average of incubation period for malaria, and that is of 7 to 14 days. For the dengue, the incubation period is 5 days and on an average less than 7 days. So, how can we use this incubation period knowledge in our examination or during the clinical practice? Remember that if there is any patient who has a history of travel and has fever, the first thing you will ask or the first thing you will do is to take you have to take the history, and you need to ask a very simple and basic question to the patient that from when you got the symptoms of fever, or from when you have been feeling feverish. If he says that it has been there, uh, uh, it has been there from last 5 days from the time of travel, then it is a case of dengue. If he says that it has been there for after 7 days of travel, then it is a case of malaria. Please remember that. Of course, the patient will have different other sign symptoms where the patient will have bone breaking fever in dengue, where the patient will have constant type of fever, where the patient will have thrombocytopenia, right? And in the malaria, the patient will have anemia, cyclic fever, chills, headache. This paroxysmal fever in malaria is very typical, right? It is very characteristic. The paroxysmal or the cyclic fever is very characteristic for the malaria. The patient may have in the daytime, the patient's temperature will be within the normal range, right? But at the end of the day, the patient will have an extreme fever, the extreme headache, and the chills also. With that, the patient will have anemia also. Remember that anemia is more towards the malaria rather than the dengue, and the thrombocytopenia is more towards the dengue rather than the malaria. Here in the dengue, the patient will have maculopapular rash also. The patient will have bone breaking fever also. But the most important point is the incubation period, less than 7 days and more than 7 days. Of course, the patient, if the patient has fever after 7 days of travel, there could be a lot of differentials. But remember that the John Muthok says that any patient who has fever after the history of travel and this fever has came after 7 days, then the first disease which you need to rule out is malaria, and that's it. Now, what are the symptoms of malaria? This is a triad from the John Muthak. If the patient has a history of travel with these symptoms, fever, chills, headache, it's a case of malaria. Please remember that. Of course, the patient will have cyclic fever, patient will have headache, anemia, and the splenomegaly. This is the life cycle of the malaria. And if you can see here, this is the Anopheles mosquito, which has this plasmodium, right? Which has this plasmodium inside. And once it stings you, okay, and this is the skin, which you can see, which is indicated with the yellow color. Once it bites you, this plasmodium is transmitted into the vessel, right? From the vessel, what will happen is that it will go into the liver, okay? And this stage is called as pre-erythrocytic stage. From there, what happens is that it multiplies, okay? It multiplies, and after multiplying, it goes into the blood, okay? It goes into the blood and into the RBCs. And when RBCs are filled up with this plasmodium, multiplying plasmodiums enough, the RBC ruptures and leading to different sign symptoms. When it ruptures, either it enters into the other RBC or it forms male and female gamete. But male and female gamete cannot fuse with RBC. You need to remember that. And it remains in the blood. When the mosquito bites again this patient, these gametes are again transmitted to the mosquito, and this mosquito is now ready to infect other humans also. Remember that at this very stage, there could be another stage also where this plasmodium sleeps and remains in the hypnozoitic stage, and if that is what we called as a sleeping stage, and if it wakes up, it enters into the exoerythrocytic stage and results in the relapse. Okay, where the uh, patient sign symptoms initially will be resolved by the treatment, but after a few days, the patient's sign symptoms relapse. The reason being is this hypnozoitic stage. Now, when you talk about the management part, either we need to cure the patient who has sign symptoms, clinical sign symptoms, or we can do the radical treatment, right? Plus, we can go for the prophylaxis also. Like, for example, there's a patient and the patient wants to travel into a place where there's a high incidence of malaria. We can go for the suppressive treatment or the casual treatment or casual prophylaxis also. Now, if we talk about the clinical treatment, we have to, if we just, try to uh, take this concept, okay, we have to hit this very stage because at this very stage, till this very stage, the patient was asymptomatic, and once this RBC is rupture, the patient gets the sign symptoms. So therefore, if we don't let this RBC rupture and kill all these plasmodiums inside this RBC, that can cure the patient and prevent the patient to have these sign symptoms. So therefore, we need to target the erythrocytic stage, right? So we have to kill them inside RBCs, and eventually this stops the symptoms. And the other one is a radical treatment. where after killing erythrocytic stage, we go for exoerythrocytic stage also, and we kill all the plasmodiums which are present in the hypnozytic or the sleeping stage. Therefore, it will prevent the relapse. And when we talk about the prophylaxis of malaria, we can go for the suppressive treatment or the casual treatment. In the suppressive, where the malaria entered into the RBC, right? And the patient and these RBCs ruptured and resulted in what? Resulted in the sign symptoms. Again, we can give some suppressive treatments where we don't let RBC rupture. Here in the erythrocytic stage of clinical treatment, we kill them inside the RBC. But here we don't kill them. We make the RBC very tough to be ruptured. So therefore, we don't let the RBC to rupture. In the casual, what will happen is that we will kill the plasmodium at pre-erythrocytic stage. This is how we approach a case of malaria. Approach a case of malaria. This is the brief concept which we'll use while solving the questions. Remember that if we talk about the primaquine, okay, it can kill all the gametes of all species of plasmodium, and that too with single dose. Number one, it can attack the exoerythrocytic stage also, and it is given for 14 days. So therefore, we kill the we can with the help of primaquine, we can take care of these uh, two stages, both the stages uh, we can take care of with the help of primaquine, right? Primaquine. But remember that there's a limitation. That means contraindication, or the patient will get the side effects of primaquine if the patient has G6PD deficiency, right? And please remember that it is contraindicated during pregnancy also, and even after delivery till 1 year, as G6PD is absent in babies. Please remember that. Okay. Once we are done with this, then we'll directly go towards the exam oriented discussion, right? Now, let me discuss it again over here. What should be the treatment now? If the patient is non-pregnant and you have to, they asked you about the treatment, please remember you go for the artemether plus lumefantrine. Okay, this is the first line. If they talk about the second line, then what you have to go for? You have to go for the atovoquinone, or you can go for the progonil. If they talk about the third line, if they don't give these two in the option, then you can go for the quinine plus doxy or clinda. And it is used in pregnancy, okay, this clinda in pregnancy and in child. So this is for uncomplicated case of malaria in non-pregnant patients. If the patient is pregnant, you can think about the quinine clindamycin, not the doxycycline. Please remember that. If the patient is having complicated malaria Then where the patient will have hypoglycemia, or the patient will have vomiting, patient can have jaundice, right? What could be this sign symptoms of complicated malaria? Altered consciousness, vomiting, hypoglycemia, acute kidney injury, oliguria, and anemia. These all are, please remember this vomiting, these all are the sign symptoms of complicated malaria. Where what we'll do is that we'll go for IV artesunate, then oral lumefantrine, or we can go for quinine, then oral quinine, IV quinine, then oral quinine. Now, if the patient is pregnant, if the patient is pregnant, if the patient is pregnant, what what we need to do? First one is if the patient has uncomplicated malaria and the patient is pregnant, the first thing you need to do is that you have to divide it whether the patient has first is in the first trimester or in second and third trimester. If it is first trimester, you can go for quinine, okay, plus clindamycin as already mentioned. If it is second and third, you can go for artemether plus lumefantrine. Artemether plus lumefantrine. Please remember that when it's a case of uncomplicated malaria. But if it is severe or complicated, go for IV artesunate if it is first trimester, or you can also go for quinine. But if it is second and third, you can only give IV artesunate and not quinine. This is what you need to know about the management part of malaria. But another important part of malaria is prophylaxis. This is being asked in your examination, so I have to remember this. If the patient is going, I will write the statements. If the patient is going to high resistant, high resistant areas, right, for 2 weeks, for less than 2 weeks, what you have to do is that you can give doxycycline 1 or 2 days. Please remember this, 1 or 2 days before and 4 weeks after travel. You will start this doxycycline 1 or 2 days before the travel, and then you'll continue it after 4 weeks of after travel, right? For 4 weeks after travel. Please remember that. Or so this is the question which they will ask you 1 or 2 days before, okay, and 4 days after, 4 weeks after travel. Or you can give melanon, melanon, right? Melanon. Please remember this. If the patient is going to high resistant areas for less than 2 weeks. Second statement. If the patient, you can go for artemether and proguanil in if the patient is going for in a low risk endemic areas, plus on short travel. When to start? Start 2 days before, just like doxy, and then during travel, of course, and 7 days after travel. Doxy was for 4 weeks after the travel. And then third one, remember that mefloquine. Mefloquine is used 2 to 3 weeks before. Please remember this, 2 to 3 weeks before, and it is taken weekly, 2 to 3 weeks before, and taken weekly, and then 4 week after the travel, right? And mefloquine is not given to peds. Remember this. Doxy is not given to peds who are less than 8 years. Fourth point is for the pregnant ladies, give chloroquine if the patient is going for chloroquine sensitive areas. If she is going to chloroquine resistant areas, you can go for mefloquine. Please remember this. Now, this is how you will remember each and every point for malaria. Now let's talk about the dengue. Important points. Remember that this is also called as bone breaking fever. So therefore the patient will have bone pain also here. The patient will have, of course, fever. Patient will have maculopapular rash also, right? The patient will have decreased platelets also. Sometimes the patient comes up with the atypical symptoms like diarrhea, but these atypical symptoms could be also present with the malaria also, where the patient will have diarrhea, abdominal pain, and cough. Please remember this, okay? Before that, I just want to mention about the diagnosis of malaria. If they talk about the diagnosis of malaria, you have to remember that you can go for the CBC, you can go for the peripheral blood smear. The important point is peripheral blood film or smear, where you go for thick and thin smear. This thick smear is used for the detection of parasite. Okay, that means uh, you can get to know, okay, this is a plasmodium, but what type of plasmodium? You have to go for the thin one. Okay, done. Other tests are like you can go for the uh, PCR also. That's what you can do. You can go for the ICT, that is immune chromatography card test, right? And the other important point which I want to mention is that the index of suspicion. If the index of suspicion for the malaria is high, then you need to repeat. Then you need to repeat the smear. You need to repeat the smear test. Okay, till three negative thick films are there. Only after that you can rule out the malaria. Done. If we are good with this, then we can now talk about the dengue, where we mentioned about these typical symptoms. Then we will discuss about the dengue, of course, where we talked about the patient will have bone pain, bone breaking fever, the patient will have fever, continuous kind of fever, maculopapular rash, and this important point, that is thrombocytopenia. Okay, this maculopapular rash, please remember that it happens after 1 to 2 days. Okay, and initially it will be a macular rash, and after 1 to 2 days, this macular rash is converted into a maculopapular rash. It just looks like a scarlet type of fever. Sorry, a rash, which is blanching. Okay, which is blanching. It initially involves the trunk, and then it goes and distributes centrifugally. Okay, and then it spreads to two things, that is palm and sole also. Done. What was the incubation period? 5 to 6 days. That means the less than 7 days. This virus basically replicates in the bone marrow, resulting in the increased capillary permeability, and where the patient will have fever, malaise, headache, nausea. Even the patient will have a retro. This is a typical symptom, a retroorbital pain. You know that this retroorbital pain is sometimes very classic for the cluster headache. Uh, there was a patient. He came with the retroorbital pain, and he was not aware that his body temperature has been raised. Okay, he was just mentioning that I have a very bad retroorbital pain. It seems like that there's some kind of nail or a splinter which has been there inside my eye and all. And then once we investigated the patient, we went for the physical examination and all. The patient was febrile to touch. We went for all the investigation. The patient had dengue later on. So yeah, I remember this is the triad for the dengue. Okay, with that, how to diagnose? You have to go for the dengue specific I, uh, IgM serology, which is best on the day 5. Please remember that. You can go for the PCR. You can go for the PCR. Done. And NS1 antigen, and the detection of viral nucleic acid during the first week of illness is basically done by this PCR NS1 antigen. You can go for the FB, where you will see leukopenia, thrombocytopenia in hemorrhagic form. Treatment is of course symptomatic, where we'll go for the paracetamol and IV fluids and all. But you need to remember that you have to avoid the antibiotics, aspirin, NSAIDs, and corticosteroids. Analgesics are taken as paracetamol and not the other ones. You have to, for the prevention, you have to avoid the mosquito bites because there is no vaccine available. If you remember that, this dengue can result in even dengue hemorrhagic fever or dengue shock syndrome, where the patient's hematocrit will be raised, the patient will have hypotension and tachycardia. Okay, if the patient has hemorrhagic form, that is the patient presents with the dengue shock syndrome, patient's hematocrit will be raised, patient will have low BP, that is hypotension, patient's heart rate will be raised, that is tachycardia. Of course, the patient can have hepatomegaly also. You need to remember this. Sometimes the patient presents with GI bleeding also. This is how, you know, the patient has a lot of symptoms. If you remember that there's a book, Davidson, right, which we usually follow in the subcontinent areas. It's Harrison or your Davidson. The Davidson writes that dengue can have vertical transmission if it is detected in mother after 7 days of delivery. That means if there's a patient who is pregnant and after the delivery she developed or you diagnosed the patient had a fever and you diagnosed that this is a case of malaria in mother, make sure that you also check the baby also, because Davidson says that dengue can transmit vertically if it's detected in mother after 5 days of travel. Done. If we are done with that, we can talk about the Zika virus. It is transmitted by the Aedes aegypti, more common in Central and South America. Most of the patients are asymptomatic, but symptoms are like fever, rash, arthralgia. Please remember this arthralgia. You have to remember this arthralgia and conjunctivitis also. With a dengue-like syndrome, okay, it can result in Guillain-Barré like syndrome. What is the other? This is virus, and there is one bacteria which can result in GBS. That is your Campylobacter jejuni. Okay. In the Guillain-Barré syndrome, the patient will have ascending paralysis. Okay, ascending paralysis. Or it can result in the cerebral damage where the patient will have microcephaly. Okay. In infants or the infected mother, diagnosis confirmed by the serology and PCR, treatment is symptomatic. Other than that, please remember that the Zika, it can result in miscarriage. Patient can have this rash, which is pruritic. Patient can have bilateral. It's worth remembering the patient can have bilateral non-purulent conjunctival infection. Please remember this. Please remember this. Okay? Please remember this. Mostly it is seen in, there was a incidence rate of Zika virus was raised in Brazil previously. Of course, we went for the serology and all. That is how we diagnose this case. For the treatment, we have to increase the hydration. We have to go for the pain control. We have to go for the antipyretic medications. For the serology, you have to go for the blood and urine serology. Okay. As an initial step, then you can think about the RT-PCR for the confirmatory. There's one important point which I want to mention is that is for the sexual intercourse if infected by the, what is the approach or what is the advice if the patient has Zika virus, and what should be the advice for the sexual intercourse if there's a history of Zika virus and the couple wants to conceive, right? Remember that if there is a travel history by husband, then please avoid the sexual intercourse for 3 months. If there's history of travel by the wife, then make sure you avoid for 8 weeks. Okay. And if there's history of travel for both, then you have to go for the serology. history of travel by boat. You have to go for the serology for Zika at 4 weeks or 2 weeks followed by 8 weeks. Done? Okay. Chikungunya. Please remember that in chikungunya, the patient will have a chick sign. If this is the nose, the patient will have this brownish type of pigmentation, the bridge of nose. That's what we call as chick sign. The patient will have arthralgia also. So in it's this is an alpha viral mosquito-borne infection with similar clinical picture to dengue fever. It can cause hemorrhagic fever. It is encountered in tropical Southeast Asia, Indian Ocean islands, and parts of Africa. Please, you have to remember that the patient will have arthralgia. Very, very important. As we are done with this, for the yellow fever, what I want you to mention, remember is that this results in hepatic failure, it results in renal failure, and it results in thrombocytopenia. We talked about the dengue, the patient had this thrombocytopenia, but with that, if the patient has hepatic and renal fever, renal failure, then it is a case of yellow fever. This yellow fever is this is the reason that the this yellow fever is also called as hemorrhagic hemorrhagic fever of tropical area. Okay, and what else? Of course, the patient will have. They say that sometimes the patient will have this albuminuria. The patient will have the faggot sign, that is the relative bradycardia, which is also seen in the typhoid. Please remember that. What is that? Normally, with every with every 1 degree Celsius raise in temperature, raise in core body temperature, there is increase in heart rate with 10 beats per minute. For example, if your normal heart rate is 72 or say 70 and your normal temperature is 37, if now your temperature is 38, the heart rate also increases. That's the reason that those who have fever, there is uh, sometimes we can say that the pulse rate also increases. So yeah, because with every 1 degree Celsius raise in core body temperature, there is increase in heart rate with 10. That is this 80. Okay, this is the normal thing which happens in each and every case of infection when there is a fever. But sometimes in typhoid and in case of yellow fever, this sign which is called as faggot sign, in which there is no increase in heart rate. So this can give us a very false perception that the does not have fever. So therefore, in each and every case, we have to go for the thermometer. We have to use the thermometer. For the yellow fever, this vaccine and it is given to each and every individual who is more than 9 months old, and it gives protection for 10 years and then it's taken again. How to diagnose? You have to go for the ELISA. That's it. That's all for the yellow fever. Now, when we talk about the Japanese encephalitis, of course, it results in the encephalitis. The treatment is supportive It is not in Australia. It is mostly seen in the other regions like in India or in China, Japan, where there are very large agricultural programs and or there is very large agriculture, and more commonly seen near the rice paddies or near the regions where there are a lot of pigs. So treatment is supportive, diagnosis done by the serology. Then we have to talk about the Murray Valley virus. Okay, it is occasionally seen in the southeastern Australia, or sometimes more importantly in northern Australia. Here the patient will have fever, patient will have CNS sign symptoms. Please remember that the Murray Valley virus will have CNS sign symptoms like confusion and all. So treatment is supportive and diagnosis is serology. So you have to remember this northern Australia. Then we have Ross River, okay, and it is again seen in northern Australia where the patient will have polyarthritis, patient will have polymyalgia, patient will have fever plus rash. So any patient who has a history of travel towards northern Australia now comes with polyarthritis, polymyalgia, fever, and rash, they go to the Ross River. Treatment is supportive. Incubation period is 7 to 9 days, or sometimes we say 3 to 21 days. Okay, diagnosis is done by the serology. Okay, the differential diagnosis is which we called as Brahma forest fever virus. It is same like it is same side where there is Ross River, uh, but the sign symptoms are very mild. Okay, that's it. Now let's talk about the traveler's diarrhea. We have already discussed about this, but I just want to mention about some few points. Let's talk about the cholera. Diagnosis is done by stool microscopy, okay, and culture. If you suspect that the patient has this cholera, make sure that for the diagnosis you have to go for the stool microscopy and culture. For the treatment, which is important part, azithromycin. What is the treatment for cholera? Azithromycin. Or you can go for the ciprofloxacin. You can go for the ciprofloxacin for the cholera. Second one, Shigella. For the diagnosis, you go for the stool culture and treatment. It is basically sportive, where you have to mention about the correct. You have to come make sure you are addressing the dehydration. If we use the antibiotics, you can go for the ceftriaxone first. Okay. If stool result is not confirmed yet, then you can go for the ciproflox or trimethoprim and sulfamethoxazole. Then third one is Clostridium. Okay. Of course, the diagnosis is stool toxins A and B. Please remember this. This is the first line diagnostic part of Clostridium. Then the treatment is, for the first episode, please remember this, because in India, Pakistan, we go for the vancomycin as first line treatment, but in Australia, they are still Clostridium difficile is still sensitive for the metronidazole. Therefore, we have to go for the metronidazole. Okay, and second line, the first line is metronidazole, and the second line is vancomycin. For the second episode, you have to again go for the metronidazole, but if it relapses again, then we can go for the vancomycin or flutoxamicin. Okay, that's it. Then fourth one, typhoid fever. When you talk about the typhoid fever, the diagnosis is blood culture. Okay, that is the confirmatory. If you remember the BASU part, blood culture within 1 week, then agglutination test, that's a Vidal test within 2 weeks, stool culture in third week, and urine culture for the fourth week. Okay, so but the best one and the confirmatory is the blood culture within 1 week. That is done by the blood culture. Treatment is azithromycin. Please remember this. This is not the ceftriaxone. This is your azithromycin orally, or we can go for ciproflox. But remember that if the patients, if we cannot give orally, okay, if the patient has very, if the patients cannot take orally, or the patient has severe nausea vomiting, then we have to go for the IV. And IV as initial treatment, uh, we can go for the ceftriaxone or IV ciproflox. Also, if the patient, so if he cannot take orally, we can go for IV. If the patient has is a child who is of 1 to 3 months, of course cannot take orally. If there is bacteremia, if there is involvement of endovascular infection, or patient has osteo uh, articular infection, that's it. Fifth one, Campylobacter. Talk about the Campylobacter, the diagnosis is done by the, yes, stool culture and PCR. Remember that. Treatment for the Campylobacter. Remember that this Campylobacter, its presentation looks like pseudoappendicitis. This is your question. Treatment is for the non-severe. You have to go for the supportive treatment. For the severe, you have to go for the azithromycin. And for the those who are having severe Campylobacter infection, alternate if the azithromycin is not available or the patient is hypersensitive, has hypersensitivity with the azithromycin, you can go for the fluoroquinolone. Remember that when you talk about the Salmonella and Shigella, okay, what we do is that those who are food handlers, should not we should advise the food handlers who have this infection of salmonella, please do not return for 72 hours after cessation of diarrhea. Okay, and if you are working in a child care service, or if you are in a child care service or in a health care or aged care, if you are a healthcare worker, child care worker, or a aged care worker, please do not return for 48 hours after the cessation of diarrhea. For Shigella, the symptomatic men should not have sex with men, please. Okay, and do not have sex for 7 days after symptoms are resolved. This is how this is very important. Okay, those who are having salmonella infection have and if the patient is a food handler working in a restaurant, you have to advise the patient to not to return to the restaurant for 72 hours after the cessation of diarrhea. They are a worker in healthcare, child care, or aged care worker. You don't have to return for 48 hours. Hopefully, this is all right. Let's go and now talk about the meningitis. Okay, this is all about the treatment and the diagnostic part. Other things, symptoms and all can be, you can watch them on the other main video of eFocus. Remember that the meningitis rash is non-blanching. But when we talked about the dengue maculopapular rash, that was blanching. Here, if the patient has meningitis, focal sign symptoms, the patient has neck rigidity, fever, vomiting, the patient has Burzynski's sign positive, Kerning sign positive, with rash, that is non-blanching. Okay, the patient has petechiae or purpuric rash. It is a very dangerous situation where the patient is infected by Neisseria meningitis. So it is a case of meningococcal meningitis. The first thing you will do is that you'll insert the IV line and start the treatment. Treatment with ceftriaxone, IV ceftriaxone, as soon as possible, SOS. Plus, you have to go for the ceftriaxone, or you can go for the Cefotex. Okay, patient will have fever, vomiting, headache, fever, vomiting, plus headache. Patient will have the neck rigidity, plus patient will have fever, already mentioned. Kerning and Brudzinski's sign may be positive. Now, if the patient is allergic to this or this is not available, you can go for the benzyl penicillin. Please remember that. For the empirical treatment, you can go for the injection with benzyl penicillin or ceftriaxone. Okay, but yeah, ceftriaxone is always there, which you have to remember. And please add corticosteroid in severe cases. For the prophylaxis, you can go for the rifampicin, which is taken orally. Then Ceftriaxone is another option, IV or ciproflox. Then sometimes they will talk about the infective endocarditis treatment at all. For the empirical treatment, it is benzyl penicillin plus gentamicin plus difloxacillin. Okay. If there is prosthetic valve involved, you have to add the vancomycin along with these. Okay. Or if it is a MRSA or hospital acquired infective endocarditis. For the prophylaxis, it is oral amox, okay, given 1 or 30 minutes before, or IV ampicillin. IV ampicillin, please remember that. And yeah, that's it for the meningitis part also. Then what else we need to remember? Um, I think we should also, I need to discuss about the management part of the management part of that is brucellosis. Yeah, that's again very important. Remember that brucellosis management part. Okay, I'm already only discussing about the management at all. Please remember, if you are pretty sure that the patient has brucellosis and it is a case of adult, you need to go for the treatment. Remember that there will be history of exposure to cows or pigs. Cow is very important. Pigs, patient will have fever and all. Now, if it's adult, go for the doxy plus rifampicin. Please remember this. 100% comes in the exam for the treatment of brucellosis. What should be given? Doxy plus rifampicin. If it's a child, you have to go for cotrimoxazole plus rifampicin. Now, another important one is Q fever. What is the important part in Q fever? Please never ever attempt for blood culture. Okay, because it's a biological agent. It can be used for the biological warfare. So therefore, yeah, we don't have to go for the blood culture treatment. If it's adult, remember that it's mostly seen in those areas or those places which is a slaughterhouse, like abattoir. It's very typical for the Q fever, this abattoir. Now the treatment in adult is none other than doxy, okay, and it can result in culture negative type of endocarditis where we have to go for the doxy. If it results in the endocarditis, we have to go for the doxy plus clindamycin or rifampicin, just like the case of brucellosis. If the patient is less than 8 year old, we can go for the cotrimoxazole plus uh, nothing but just the cotrimoxazole. We don't add rifampicin over here. How do you diagnose this case of Q fever? Just PCR test. Please remember that if we talk about hepatitis now, We have hepatitis A, we have hepatitis B, and we have hepatitis C, and we have hepatitis D. Hepatitis A and uh, D and E. Hepatitis A and E, those which are at the extremes, they have fecal oral route. In hepatitis A, travelers who are aged, what are the important points? Travelers who are aged more than 1 year, they should be vaccinated with hepatitis A. That's important. Travelers, any traveler who is more than 1 years of age, he needs to go for the hepatitis A vaccination. Please remember that this is the MCQ. Second, those who are having men sex with men. Third, people who inject drugs, those who are drug abusers. Fourth one is those from Aboriginal Torres Strait Islanders. Fifth one is people who have chronic liver disease. Okay. Immunoglobulins uh, can also be given to fulminant hepatitis A or in patients who have very severe hepatitis A, and immunoglobulins, which is like 0.03 to 0.06, it confirms a satisfactory passive immunity. For the hepatitis B, the patient can have urticaria. Please remember this. Patient will have arthralgia. Okay. Please remember this. The patient can have urticaria, itching. Patient can have arthralgia, bone pain, and other things, which is followed by jaundice. Okay. And such patients who are hepatitis B, they should go for 6 monthly for LFT, okay, with fibroscan also. Please remember this. Treatment is anti-cabin, tenofovir. Uh, we can also go for the peg interferon, okay, and we have hepatitis B vaccine, okay. Yeah, so we have anti-cabin, we have tenofovir, we have pegylated interferon also. Uh, that's it. Now for the hepatitis C, we use direct acting antivirals like sofosbuvir, simipravir, dasabuvir, and the other ledipasvir is also used. But the diagnostic part is important, where we go for the PCR hepatitis C virus if positive, plus if the patient has significant viral load, plus the patient has raised ALT. If the patient has PCR HCV positive, patient has significant viral load plus raised LFT, we have to go for genotyping then for hepatitis C virus. Okay, to determine the treatment. Please remember this. Please remember this. If the patient has PCR positive, significant viral load, raised ALTs, we have to go for the genotyping for hepatitis C virus for determining the treatment. Mm, but it was the previous, okay, I have mentioned this, but it was the previous guidelines. Now they say that we can directly start the direct acting antivirals. For the hepatitis D, we can go for the treatment with the pegylated interferon and all for 48 months. That's it. Mm, remember that the vertical transmission, right? Baby can have maternal antibodies of for the hepatitis C for 18 months. Therefore, doing test early is not reliable. In those patients, like for example, there's a mother. who has hepatitis C, and she has a baby inside, and now she delivers this baby. For first 18 months, don't do any investigation, because she already, because this neonate will have this uh, hepatitis C antibodies from the mother. But once after 18 months, do investigations. Check the status of hepatitis C. Check the status of hepatitis. Now, some extra miles. If there is a patient of a rheumatic fever, where we use the Jones criteria, where the patient will have joint pain, patient will have or pancreatitis, patient will have subcutaneous nodules, patient will have erythema marginatum, and the Sydenham scoria, where we can use carbamazepine, and valproic acid is sometimes also used for such patients who have this scoria. Now, what is the treatment? It is for the acute rheumatic fever. The treatment is benzyl penicillin IM, okay, as a single dose, or 10 days of oral penicillin V, okay. For the rheumatic fever, benzyl penicillin as a single dose, or 10 days of oral penicillin V. If the patient has arthritis, or it's a severe case of arthralgia with acute rheumatic fever, we can use aspirin or naproxen. If the patient has a recurrent acute rheumatic fever uh, risk, so therefore we have to go for the prevention, and where we go for the IM benzathine benzyl penicillin, just like the treatment part. Just it is just like we went for the treatment, or we can go for orally phenoxy methyl penicillin. For the treatment, we went for the we went for the benzethyl, we went for the benzathine benzyl penicillin IM as a single dose, or 10 days of oral penicillin V. If the patient had arthritis or severe arthritis, we went for the aspirin naproxen. For the recurrent, if there's a risk for the recurrent acute rheumatic fever, for the prevention, we again went for the IM benzathine uh, benzyl penicillin, or orally phenoxymethyl penicillin. Remember that if the patient has went for the splenectomy, so therefore post question is post splenectomy. Post splenectomy case, what do? You go for the long term management with amoxicillin or ampicillin or phenoxymethyl penicillin for 3 to 4 years. Please write this. Once you go for the splenectomy, after that you give the patient long-term amoxicillin or ampicillin or phenoxymethyl penicillin for 3 to 4 years. If in between the patient gets abscess, okay, if the patient gets this abscess or sepsis, you have to go for the 6 month prophylaxis with same, in addition to the previous long-term treatment. Now, what else? Do we have anything else? I just want to mention one point over here. If the patient has orbital cellulitis, What is the treatment? We have to go for the IV ceftriaxone, okay, plus flucloxacillin. Make sure you go for the CT scan. Please remember this. CT scan of brain, sinus, and orbits. It's always done. Now, is there anything else which I didn't mention over here? Just looking around if there's any other important point which I need to mention. Oh yeah, just one last point. If they mention that the patient is having, uh, see, this is the gallbladder. The patient can have cholecystitis, and this cholecystitis is of two types. One is due to the calculus, which is called as calcular cholecystitis, and the other one is acalcular cholecystitis. I, yeah, it's very common sense that calcular cholecystitis, inflammation of gallbladder, may be due to the uh, stone which may stuck in the cystic duct, resulting in inflammation of the gallbladder. That's what we call as calcular cholecystitis. Other one is acalcular cholecystitis. This is seen in those who are septic patients, those who are ill, those who are who had the recent history of burn and all. In short, those patients who are very sick, they can have this acalcular cholecystitis. So, what are the antibiotics which are used for such patients for the empirical treatment? It is gentamicin for the calcula plus amoxicillin. Okay, if gentamicin is contraindicated, like for example, the patient has myasthenia gravis, there is drooping of the eyelids and all, or with the increase in work, the patient there is muscle weakness. So gentamicin is contraindicated. So what we have to do, we can go for the ceftriaxone in those cases. For the A calcula, we can we have gentamicin plus metronidazole, okay, plus amox. So we have three things over here. Again, if the patient has gentamicin contraindication, like for example myasthenia, for this we don't go for the ceftriaxone, we go for the piptaz. It's piperacillin plus tazobactam. If they talk about the pain management in pregnancy, please go for the PCM and avoid the other NSAIDs. This is all about the infectious medicine. Okay, the important points. Please just get very familiar about the clinical features, and for the management and the investigatory part, you can just revise through this video. Okay, so yeah, that's it for today. Hope we will meet soon and talk about the different things again. So, yeah, take care. Bye bye.